Welcome back, everyone. Today we are moving away from the crowded main terminal of the wrist, the carpal tunnel, and heading over to the VIP side entrance. We're talking about the Tunnel of Guyon, also known as the ulnar canal. Dr. Sarah, are you ready to get into the weeds of the medial wrist?
Absolutely, Dr. Khan. While the carpal tunnel gets all the fame, the Tunnel of Guyon is a favorite for board examiners because it requires a precise understanding of ulnar nerve anatomy. It's that small fibro-osseous space on the medial, or ulnar, side of the wrist.
Medial side, exactly. I like to think of it as a small, specialized garage. It's much smaller than the carpal tunnel, and it's basically there just to protect two very important guests, the ulnar nerve and the ulnar artery. But before we talk about the guests, let's talk about the walls of this garage. Sarah, set the scene for us.
For your exams, you must know the bony landmarks. The lateral boundary, which is also proximal, is the pisiform bone. The medial and distal boundary is the hook of the hamate. These two carpal bones form the floor and sides, while the roof is formed by the palmar carpal ligament and the palmaris brevis muscle.
Okay, so we've got the pisiform and the hook of the hamate. Why does this matter clinically? Well, if you've ever fallen on an outstretched hand or spent hours gripping the handlebars of a mountain bike, you are putting direct pressure on that roof. In the clinical world, we often call ulnar compression here handlebar palsy. It's a classic presentation for cyclists.
That's a high-yield clinical association. Now, when the ulnar nerve enters this tunnel, it actually splits into a superficial branch and a deep branch. The superficial branch is primarily sensory to the palmar surface of the fifth finger and the medial half of the fourth. The deep branch? That's almost entirely motor. It handles the heavy lifting for the intrinsic muscles of the hand.
And that heavy lifting is no joke. Think of the deep branch as the master electrician for the hand. It powers all the interossei, the muscles that let you spread your fingers apart and bring them together, plus the two medial lumbricals and the adductor pollicis. If that electrician goes on strike because of compression in Guyon's canal, your hand loses its fine motor skills. Why does this matter clinically? Because without those muscles, you get a weak grip and potentially that characteristic ulnar claw look.
Let's pause there, because boards love to ask you to differentiate Guyon's canal compression from cubital tunnel syndrome at the elbow. Here is the pro tip. Check the back of the hand. The dorsal cutaneous branch of the ulnar nerve leaves the main nerve about 5 centimeters above the wrist. It does not pass through the Tunnel of Guyon.
That is a golden nugget right there. So if a patient has numbness on the palm side of the pinky, but the back of their hand feels totally normal, the problem is likely at the wrist, not the elbow. It's like a detour that happens before the toll booth.
Exactly. If the sensation on the dorsum of the hand is intact, the lesion is at or distal to the wrist. Now, Dr. Khan, what about the motor testing? How do we see this in action?
We look for Frohman's sign. I ask the patient to hold a piece of paper between their thumb and index finger using only adduction. If the ulnar nerve is compressed in the canal, the adductor collicis is weak. To keep hold of the paper, the patient will instinctively flex the tip of their thumb using the flexor pollicis longus instead. Since that's a median nerve muscle, it stays strong. It's a beautiful way to see the ulnar nerve failing in real time.
And from an academic standpoint, remember the PAD and DAB mnemonic. Palmar interossei adduct, dorsal interossei abduct. If they can't dab, spread their fingers against resistance, you're looking at ulnar nerve motor deficit, likely deep branch involvement within or distal to the canal.
You know, I once sent a patient to a hand specialist. He was the doctor of choice in our region for these types of cases. And it turned out the guy didn't have cyclist palsy at all. He had a small fracture of the hook of the hamate from playing golf. That bony hook snapped and was poking right into the nerve inside the tunnel.
That is another classic board scenario. A golfer or a baseball player with wrist pain and ulnar nerve symptoms often has a hamate fracture. It's the perfect anatomical storm. The hook of the hamate is literally one of the pillars of the tunnel.
It really is. And let's not forget the ulnar arteries in there too. While it's less common to see major arterial issues here compared to the nerve, repetitive trauma can cause ulnar artery thrombosis, also known as hypothenar hammer syndrome. If you use the palm of your hand like a hammer to fix things, you're essentially crushing the artery against the hook of the hamate.
High yield point. The ulnar artery is lateral to the ulnar nerve within the canal. If you have to identify them on a cross-section, remember that the nerve is more medial. Nerve, then artery, then the hook of the hamate.
So why does all of this matter clinically? Because early recognition prevents permanent muscle wasting. If a patient comes in with clumsy fingers and numbness in the pinky, don't just assume it's carpal tunnel. Look at the medial side, check the cyclist history, check for that hamate tenderness.
And to summarize for the students, Guyon's canal is between the pisiform and the hook of the hamate. It contains the ulnar nerve and artery. Unlike cubital tunnel syndrome, Guyon's canal compression spares the sensation on the back of the hand. If you remember that, you've got half the exam questions beat.
Beautifully put, Sarah. The Tunnel of Guyon. Small space, huge clinical impact. Thanks for the deep dive.